Hello everyone, my name is Kylie Sheppard and I'm going to be doing a presentation over hyperinflation therapy today. So what is hyperinflation therapy? Hyperinflation therapy is used to increase lung volumes and it often aids in secretion mobilization. Attached here is a picture of the lungs and the heart, and it has different sections that tells you what effects hyperinflation has on the system. So what are our indications for PEP therapy? These are going to include acute and chronic respiratory failure due to surgery, neurological and musculoskeletal dysfunction, immobility, to increase lung volume by increasing FRC and VT, reduce hyperinflation and air trapping, and improve airway clearance. So just to elaborate a little bit on these, when a patient has surgery, depending on the location, they are often bedridden, and if they have an abdominal surgery or a chest surgery, it is going to cause them a lot of pain to take a deep breath or to cough, and so this isn't going to expand their lungs normally, and that is when we need to do these hyperinflation therapies. And then for immobility, it is for a lot of the same reasons. So immobility can be for many reasons, whether it be old age, an injury, etc. Again, these lungs aren't inflating as large as they normally do, which is why we need to use the hyperinflation therapy to give them what would be those big deep breaths. For neurological and musculoskeletal dysfunction, they could have had a C-spine injury that has weakened their diaphragm and they can't cough effectively or take those big deep breaths effectively, and that's when we need to implement this therapy. So what are our contraindications? These include untreated pneumothorax, high intracranial pressure, hemoptysis, facial injury, hemodynamic instability, and more. So for an untreated pneumothorax, we don't want to increase any more pressure by giving this therapy, and the same goes for high intracranial pressure. The body is under so much pressure already, we don't want to do more harm than good by giving these therapies. For hemoptysis, if they're throwing up blood, they're not going to be able to complete the therapy properly. The same goes for facial injury. If they have injuries on their face, they're not going to be able to get a tight seal on the mouthpiece and complete this therapy in the proper way. And another thing to consider is the mental status of a patient. If they are confused, they're not going to be able to follow directions to complete these therapies. So what hyperinflation therapies are available? We have TheraPEP, OPEP, which includes acapella and arabica, and more, IPV therapy, EasyPAP, IPPB, CPAP, and more. For our TheraPEP device, this can be used to accommodate patients over a wide range of lung capacities. The TheraPEP device provides a series of fixed orifices. The smaller the orifice, the greater the expiratory pressure generated. The higher the expiratory flow, the greater the expiratory pressure generated. The patient must be able to achieve a flow of 10 to 20 centimeters of water and an IE ratio of 1 to 3 or 1 to 4. We want our patients to perform 3 sets of 10 with a cough between each set. Our only problem with this device is being able to achieve that minimum flow and IE ratio. For our EasyPAP, this improves the functional residual capacity. It is a positive airway pressure system. We're going to set the flow meter at 5 to 15 liters a minute. The patient breathes in and out normally on the mouthpiece. This device reduces dynamic hyperinflation, which achieves relief of the respiratory muscles and allows for better breathing. IPV therapy. This is a high-frequency intrapulmonary percussive ventilator. It delivers a rapid series of pressurized gas mini bursts. It has a venturi in it that creates a high-frequency percussion during inspiration and expiration, which results in a pressure gradient. During the percussive cycle, the patient can inhale and exhale through the device. OPEP. OPEP is oscillatory positive expiratory pressure. OPEP devices use mechanisms to create a series of short occlusions of expiratory flow to generate oscillatory airway pressure and flow waveforms. A higher oscillation index indicates better mechanical performance characteristics. Many devices have similar characteristics, but the devices with the highest oscillation index have the highest flow amplitude and frequency, which may indicate better clinical performance. Next, we have our acapella, which is an OPEP device, and as you can see here, it has a resistance dial. This is the body of the device. It has a one-way valve and the mouthpiece. So the patient is able to breathe in and out through their mouth on this mouthpiece. The expiration causes this valve to flutter and vibrate the patient's chest. You're going to want your patients to complete 3 sets of 10 with a nice strong cough in between sets. Studies have shown that the addition of acapella improves lung volumes and airway clearance in the early post-operative period for CABG patients. The study was done over 20 patients of both genders who had undergone CABG and were in the phase 1 of cardiac rehabilitation of a randomized control trial. Patients in the control group were given conventional physiotherapy that included breathing exercises, incentive spirometry, and manual techniques. Patients in this experimental group used an acapella device along with the conventional intervention, and the outcome measures considered were pulmonary function parameters and the amount of sputum expirated. Our results were a significant increase in lung volumes was observed in both groups. However, the increase was significantly greater in the experimental group than in the control group. The amount of sputum expiration significantly greater in the experimental group as compared to the control group. So this is that information that supports that our acapella does provide good and effective therapy for these patients. Next, we have our Arabica, which is another OPEP device. And as you can see here, this device has the option to attach a nebulizing treatment. You can use it with or without, depending on your patient's needs. This is the mouthpiece that you're going to have your patient inhale and exhale on, and the exhalation is going to cause a vibration in the patient's chest. Patients need to complete 3 sets of 10 with a nice strong cough in between each set. Our Arabica device has been shown to help COPD patients achieve better lung performance and overall health-related life satisfaction. A retrospective cohort study was done comparing the use of Arabica and acapella devices on post-discharge hospital admissions in chronic bronchitis or COPD patients. The study concluded that patients who delivered the Arabica OPEP device had lower rates of recurrent severe illnesses and hospital admission than those who received the acapella. Another study was done on analyzing the efficacy of an OPEP device in COPD, showed that the utilization of the Arabica device improved airflow, which influences the patterns of concurrent prescription drug deposition in COPD patients. According to the findings on both literatures, both the Arabica device and the acapella device can reduce length of stay in the hospital and readmission. Both of these devices are effective in clearing out secretions and improving lung functions in COPD patients, and it is also used in post-exacerbation care. The impact of PEP therapy. In subjects with COPD, the effect of PEP therapy on lung hyperinflation is unclear. An effect of PEP therapy on RV was shown, but the certainty of evidence is low owing to the non-consistent change in lung hyperinflation outcomes, insufficient data, and lack of high-quality trials. There was a consistent enhancement in dyspnea and physical capacity with PEP therapy. However, more data is needed to confirm these findings. In general, trials with longer treatment duration showed a greater impact of PEP therapy. I suggest that the effect of PEP treatment duration should be verified in future investigations. Considering the high prevalence of hyperinflation in patients with COPD and its consequences for quality of life, exercise tolerance, and dyspnea, it is imperative to address these issues in future research. Next, we have the IPPB. The IPPB is a specialized form of non-invasive ventilation used for short-term treatment periods. This machine provides assisted deep breathing that helps the patient take a deep breath and stimulate a cough. Lung volumes are increased with this device. This device is not commonly used anymore, but it is still important to understand how it functions and the benefits it provides. Next, we have the CPAP. This is a continuous positive airway pressure. The patients breathe from a pressurized circuit that incorporates a threshold or flow resistor and the expiratory limb. All four operate on the principle that the level of PAP generated within the circuit depends on the amount of resistance that must be overcome to allow gas to exit the exhalation valve. This device reduces air trapping. The airway pressure maintained is 5 to 20 centimeters of water on inspiration and expiration, and the four types of the threshold resistors are the underwater seal, weighted ball, spring-loaded, and the magnetic valve. These are my references listed in order. Please let me know if you have any questions. I would be happy to elaborate on the case studies or any of the information I found. Thank you.